Hello everyone, and welcome back to another chapter of Advanced Pharmacology. Today we're talking about chapter 33, drug abuse, major drugs of abuse other than alcohol and nicotine. So we'll jump right on in. Major drugs of abuse that exclude alcohol and nicotine. In this chapter, we will discuss all the major drugs of abuse except alcohol, which was discussed in chapter 31, nicotine that was discussed in chapter 32. Again, as indicated in this following table, abuse drugs fall into six major categories. We have our opioids, our psychostimulants, depressants, psychedelics, anabolic steroids, and the miscellaneous drugs that didn't fall into any of the other five categories. The basic pharmacology of many of these drugs is presented in previous chapters, so the discussion here may be brief. Agents that have not been addressed previously include marijuana, the D-lysergic acid dithylamide or LSD, which will be discussed in further detail here. Again, here's this table where we're going to talk about some of the other drugs that are being abused. It's a good spot to hit pause if I'm ever going too quickly. I know tables and some things I just don't read over, so here's your option to hit that pause button. So let's jump into heroin, oxycodone, and other opioids. The opioids are major drugs of abuse. As a result, most opioids are classified as a Schedule II substance. Their basic pharmacology was discussed in Chapter 22. The patterns of use. For most abusers, initial exposure to opioids occurs either recreationally or in the context of pain management in a medical setting. The overwhelming majority of individuals who go on to abuse opioids begin their drug use illicitly. Only an exceedingly small percentage of those exposed to opioid therapy develop a pattern of compulsive drug use. Opioid abuse by healthcare providers deserves special consideration. It is well established that physicians, nurses, and pharmacists, as a group, abuse opioids to a greater extent than all other groups with similar educational backgrounds. The vulnerability of healthcare professionals to opioid abuse is primarily due to drug access. So, subjective and behavioral effects. Moments after IV injections, heroin produces the sensation of pleasure, relaxation, warmth, and thirst. This initial reaction, known as the rush or kick, persists for about 45 seconds. After that, the user experiences a prolonged sense of euphoria. These extended effects, rather than the initial rush, are the primary reason for opioid abuse. Interestingly, when the individual first uses opioids, nausea and vomiting are prominent and an overall sense of dysphoria may be felt. In many cases, were it not for peer pressure, individuals would not continue opioid use long enough to allow these unpleasant reactions to be replaced by a more agreeable experience. Preferred drugs and routes of administration. In the past, heroin was the most commonly abused opioid drug. However, that is no longer the case. Prescription opioid analgesics are now abused much more commonly than heroin. In 2014, more than 4.9 million Americans reported past month abuse of these drugs. So, speaking on heroin specifically here, among street users, heroin is a traditional opioid of choice. Because of its high lipid solubility, heroin crosses the blood-brain barrier with ease, causing effects that are both immediate and intense. This combination of speed and intensity sets heroin apart from other opioids. According to the 2014 National Survey on Drug Use and Health, 435,000 Americans 12 years and older reported past month abuse of heroin. This number has risen secondary to changes made in prescription drugs. Heroin is both cheaper and sometimes easier to obtain than a prescription opiate. Heroin can be administered in several ways. The order of preface is IV injection, smoking, or nasal inhalation. IV injection produces effects with the greatest intensity and fastest onset. When heroin is smoked or snorted, effects develop more slowly, peaking in 10 to 15 minutes. Among users who seek addiction treatment, injection is the predominant method of administration. However, because sniffing and smoking are safer and easier than an injection, these routes have become increasingly popular. It should be noted that when heroin is administered orally or subcutaneously, as opposed to the IV, its effects cannot be distinguished from those of morphine and other opioids. This observation is not surprising given that once in the brain, heroin is rapidly converted into morphine, its active form. Which brings us to oxycodone. In some parts in the United States, people are abusing the controlled release formulation of oxycodone, also known as OxyContin, an opioid similar to morphine. The controlled release tablets are designed to provide a steady level of oxycodone over an extended time and are safe and effective when swallowed intact. However, abusers do not ingest the tablets whole. Rather, they crush the tablets and then either snort the powder or dissolve it in water and then inject it into an IV form. As a result, the entire dose is absorbed immediately, producing blood levels that are dangerously high. Hundreds of deaths have been reported, and the risk for respiratory depression and death is greatest in people who have not developed tolerance to opioids. In an effort to reduce OxyContin abuse, the controlled release tablets were reformulated in 2010. The new formulation bears an imprint OP rather than OC, which appeared in the old formulation. Compared with the old tablets, OxyContin OP tablets are much harder to crush into a powder, and when exposed to water or alcohol, the tablets just form into a gel, rather than into a solution that can be drawn into a syringe and then be injected. However, there is no evidence that OxyContin OP tablets are less subjective to abuse, diversion, overdose, or addiction than the old tablets. Which brings us to the tolerance and physical dependence. With prolonged opioid abuse and use, tolerance develops to some pharmacologic effects, but not to others. Effects to which tolerance does develop include euphoria, respiratory depression, and nausea. In contrast, little or no tolerance develops to constipation and meiosis. Because tolerance to respiratory depression develops in parallel with tolerance to euphoria, respiratory depression does not increase because higher doses are taken to produce desired subjective effects. A person tolerant to one opioid are cross-tolerant to other opioids. However, there is no cross-tolerance between opioids and the general central nervous system depressants, so your barbiturates, benzodiazepines, and alcohol, leading us to physical dependence. Long-term use produces substantial physical dependence. The abstinence syndrome resulting from opioid withdrawal was described in Chapter 22. It is important to note that although the opioid withdrawal syndrome can be extremely unpleasant, it is rarely dangerous. After the acute abstinence syndrome, which fades in 10 days, opioid addicts may experience a milder but protracted phase of withdrawal. This second phase, which may persist for several months, is characterized by insomnia, irritability, and fatigue. Gastrointestinal hyperactivity and premature ejaculation may also occur. So, the treatment of acute toxicity. Treatment of an acute opioid toxicity again was discussed in Chapter 22 and summarized here. Overdose produces a classical triad of symptoms: your respiratory depression, comas, and a pinpoint pupil. Narcan, the opioid antagonist, is the treatment of choice. This agent rapidly reverses all signs of opioid poisoning. Again, however, dosage must be titrated carefully because if too much is given, the addict will swing from a state of intoxication to one of withdrawal. Owing to its short half-life, Narcan must be re-administered every few hours until opioid concentrations have dropped to a non-toxic level, which can take several days. Failure to repeat Narcan dosing may also result in death of patients who had earlier been rendered symptom-free. Detoxification. A person or persons who are physically dependent on opioids experience unpleasant symptoms if drug use is abruptly discontinued. Techniques for minimizing this discomfort are presented next. So, the first option would be a methadone substitution. Methadone, a long-acting oral opioid, is the agent most commonly employed for easing withdrawal. The first step in methadone-aided withdrawal is to substitute methadone for the opioid on which the addict is dependent upon. Because opioids display cross-dependence with another one, methadone will prevent an abstinence syndrome. After the subject has been stabilized on methadone, withdrawal is accomplished by administering methadone in gradually smaller doses. The resultant abstinence syndrome is mild, with symptoms resembling those of a moderate flu. The entire process of a methadone substitution and withdrawal takes about 10 days. When substituting methadone for another opioid, suppression of abstinence syndrome requires that methadone dosage be closely matched to the existing degree of physical dependence. Therefore, to ensure that methadone dosing is adequate, the extent of physical dependence must first be assessed. This can be accomplished by taking a history on the extent of drug use and by observing the patient for symptoms of withdrawal. Of the two approaches, observation is more reliable. Estimates of drug use based on patient history may be unreliable because street users generally don't know the purity of the drug that they have taken. Claims of drug use may be inflated in hope of receiving a larger dose of methadone, and addicts from the ranks of the healthcare professions may report minimal consumption to downplay the extent of their abuse. Because information from addicts is not likely to permit accurate assessment of dependence, it is essential to observe the patient to make certain that the methadone dosage is sufficient and to suppress withdrawal. Use of methadone for maintenance therapy and suppressive therapy are discussed separately here later on. Methadone does have a black box warning. Methadone can cause life-threatening QT prolongation, as well as severe respiratory depression. Because of its long half-life of methadone, it should only be prescribed by a healthcare provider who has special training in chronic pain management. Which brings us to buprenorphine. Buprenorphine is an agonist-antagonist opioid, similar to methadone. Buprenorphine can be substituted for the opioid on which the addict is physically dependent and can thereby prevent symptoms of withdrawal. After the addict is stabilized on buprenorphine, the dosage is gradually reduced, therefore keeping symptoms of withdrawal to a minimum. The use of buprenorphine for maintenance therapy is discussed below. The clonidine-assisted withdrawal. Clonidine is a centrally acting alpha-2 adrenergic agonist. When administered in an individual physically dependent on opioids, clonidine may suppress some of the symptoms of abstinence. Clonidine is the most effective against symptoms related to autonomic hyperactivity, so your nausea, vomiting, and diarrhea. Modest relief is provided from the muscle aches, restlessness, anxiety, and insomnia. Opioid cravings are not diminished. The basic pharmacology of clonidine is discussed in Chapter 15. So, that brings us to the drugs for long-term management of opioid addiction. Three kinds of drugs are employed for the long-term management. Again, it's our opioid agonists, opioid agonist antagonists, and opioid antagonists. Our opioid agonists, such as methadone, and agonist antagonists, such as buprenorphine, substitute for the abused opioid and are given to patients who are not yet ready for detoxification. In contrast, opioid antagonists, such as naltrexone, are used to discourage renewed opioid use after detoxification has been accomplished. Drugs used for long-term management of opioid addiction are shown in the following table here. Again, it's an excellent spot to hit pause if you're unfamiliar, but it'll pretty much list methadone, buprenorphine, and naltrexone. So, speaking on methadone, in addition to its role in facilitating opioid withdrawal, methadone can be used for maintenance therapy and suppressive therapy. These strategies are employed to modify drug-using behaviors in addicts who are not ready to try withdrawal. Methadone maintenance consists of transferring the addict from the abused opioid to oral methadone. By taking methadone, the addict avoids both withdrawal and the need to procure illegal drugs. Maintenance dosing is done once a day. Maintenance is most effective when done in conjunction with non-drug measures directed at altering patterns of drug use. Suppressive therapy is done to prevent the reinforcing effects of opioid-induced euphoria. Suppression is achieved by giving the addict progressively larger doses of methadone until a very high dose of about 120 milligrams per day is reached. Building up to this dose creates a degree of tolerance, and therefore no subjective effects are experienced from methadone itself. Again, because the cross-tolerance exists among opioids, after the patient is tolerant to methadone, taking street drugs, even in high doses, cannot produce significant desirable effects. So as a result, individuals made tolerant with methadone will be less likely to seek out illicit opioids. Use of methadone to treat opioid addiction is restricted to opioid treatment programs approved by the designated state authority and certified by the Federal Substance Abuse and Mental Health Service Administration. These restrictions on the non-analgesic use of methadone are needed to control abuse of methadone, a Schedule II drug with the same abuse liability as morphine and other strong opioids. The basic pharmacology of methadone was presented in Chapter 22. Which brings us to buprenorphine. Buprenorphine, also known as Suboxone, is an agonist-antagonist opioid. The drug is a partial agonist at mu receptors and a full antagonist at the kappa receptors. Buprenorphine can be used for maintenance therapy and to facilitate detoxification. When used for maintenance, buprenorphine alleviates craving, reduces use of illicit opioids, and increases the retention in therapeutic programs. Unlike methadone, which is available only through certified opioid treatment programs, buprenorphine can be prescribed and dispensed in general medical settings, such as the primary care office. Prescribers must receive at least 8 hours of authorized training and must register with the Substance Abuse and Mental Health Service Administration. Buprenorphine has several properties that make it attractive for treating addiction. Because it is a partial agonist at mu receptors, it has a low potential for abuse, but can still suppress cravings for opioids. If the dosage is sufficiently high, buprenorphine can completely block access of strong opioids to mu receptors and can therefore prevent opioid-induced euphoria. With buprenorphine, there is a ceiling to respiratory depression, which makes it safer than methadone. Development of physical dependence is low, and therefore withdrawal is relatively mild. Buprenorphine is currently available in 4 formulations that are dosed once a day. One formulation, the sublingual tablets marked as Subutex, contains buprenorphine alone. The other 3 formulations, sublingual tablets, sublingual film, and buccal film, marketed as Suboxone and Bunavail, contain buprenorphine combined with naloxone. Subutex is used for the first few days of treatment, and then Suboxone is used for the long-term maintenance. The newest film, Bunavail, is placed on the inside of each cheek and is used for long-term maintenance. The naloxone in Suboxone is there to discourage IV drug abuse. If taken intravenously, the naloxone in Suboxone will precipitate withdrawal. However, with sublingual administration, very little naloxone is absorbed, and therefore, when the drug is administered as intended, the risk for withdrawal is low. Nonetheless, because there is a small risk for sublingual Suboxone treatment is initiated with Subutex, thereby allowing substitution of buprenorphine for an abused opioid. Thereafter, Suboxone is taken for maintenance. Again, the basic pharmacology of buprenorphine was discussed in Chapter 22. Naltrexone. Naltrexone. After a patient has undergone opioid detoxification, naltrexone or Revio, a pure opioid antagonist, can be used to discourage renewed opioid abuse. Benefits derive from blocking euphoria and all other opioid-induced effects. By preventing pleasurable effects, Naltrexone eliminates the reinforcing properties of opioid use. When the former addict learns that taking an opioid cannot produce the desired response, drug-using behavior will cease. Naltrexone is not a controlled substance, and therefore prescribers require no special training or certification. Naltrexone is available in oral and intramuscular formulas. The oral formulation sold as Revia is dosed once a day. The IM formulation, sold as Vivitrol, is dosed once a month. At this time, Vivitrol is the only long-acting drug for managing opioid addiction. All other drugs must be taken every day. Again, the basic pharmacology of naltrexone was discussed in Chapter 22. Which brings us to the general central nervous system depressants. A family of CNS depressants consists of our barbiturates, benzodiazepines, alcohol, and a couple other agents. With the exception of benzodiazepines, all of these drugs are more alike than different. Benzodiazepines have properties that set them apart. The basic pharmacology of benzodiazepines and barbiturates and most other CNS depressants are presented in Chapter 27. The pharmacology of alcohol was discussed in Chapter 31, so the discussion in this chapter is limited to the abuse of these drugs. So, we'll touch up on barbiturates. The barbiturates embody all of the properties that typify general CNS depressants, and therefore can be considered prototypes for this group. Depressant effects are dose-dependent and range from mild sedation to sleep to coma to death. With a prolonged use, a barbiturate produces tolerance and physical dependence. The abuse liability of a barbiturate stems from their ability to produce subjective effects similar to those of alcohol. If barbiturates with the highest potential for abuse have a short to intermediate duration of action, these agents, amorbarbital, pentobarbital, and secobarbital, are classified under Schedule II of the Controlled Substance Act. Other barbiturates appear under the Schedule III and IV. Despite legal restrictions, barbiturates are available cheaply and in abundance. Which brings us to their tolerance. Regular use of barbiturates produce tolerance to some effect, but not to others. Tolerance to subjective effects are significant. As a result, progressive larger doses are needed to produce a desired psychological response. Unfortunately, very little tolerance develops to respiratory depression. So, consequentially, as barbiturates use continues, the dose needed to produce a subjective effect moves closer and closer to the dose that can cause respiratory arrest. Individual tolerance to barbiturates show cross-tolerance with some of the other CNS depressants. However, little or no cross-tolerance develops towards opioids. The physical dependence and withdrawal techniques, chronic barbiturate use, can produce substantial physical dependence. Cross-dependence exists between barbiturates and other CNS depressants, but not with opioids. When physical dependence is great, the associated abstinence syndrome can be severe, sometimes even fatal. In contrast, the opioid abstinence syndrome, although unpleasant, is rarely life-threatening. One technique for easing barbiturate withdrawal employs phenobarbital, a barbiturate with a long half-life. Because of cross-dependence, substitution of phenobarbital for the abused barbiturate suppresses symptoms of abstinence. After the patient has been stabilized and the dosage of phenobarbital is gradually tapered off, thereby minimizing symptoms of abstinence. Its acute toxicity. Overdose with barbiturates produces again the triad of symptoms: respiratory depression, coma, and pinpoint pupils. The same symptoms that accompany opioid poisoning. Treatment is directed at maintaining respirations and removing the drug. Endotracheal intubation and ventilatory assistance may be required. Details of management are discussed in Chapter 27. Barbiturate overdose has no specific antidote. Narcan, which reverses poisoning for opioids, is not effective against poisoning by barbiturates. So, that brings us to the next one, benzodiazepines. Benzodiazepines again differ significantly from barbiturates. Benzodiazepines are much safer than the barbiturates, and overdose with oral benzodiazepines alone is rarely lethal. However, the risk for death is greatly increased when oral benzodiazepine is combined with other CNS depressants, so your alcohol and barbiturates, or when benzodiazepines are administered intravenously. If a severe overdose does occur, signs and symptoms can be reversed with flumazenil, also known as romesicone, a benzodiazepine antagonist. As a rule, tolerance and physical dependence are only moderate when benzodiazepines are taken for legitimate indications, but can be substantial when these drugs are abused. In a patient who develops physical dependence, the abstinence syndrome can be minimized by withdrawing benzodiazepines very slowly over a period of months. The abuse liability of the benzodiazepines is much lower than that of the barbiturates. So as a result, all benzodiazepines are classified under Schedule 4 of the Controlled Substance Act. Benzodiazepines will be discussed further in Chapter 27. Which brings us to the psychostimulants. The discussion here focuses on two CNS stimulants that have a high potential for abuse. The big ones, cocaine and methamphetamine. Because of their considerable abuse liability, these drugs are classified as Schedule II agents. Cocaine. Cocaine is a stimulant extracted from the leaves of the cocoa plant. The drug has CNS effects similar to those of amphetamines. In addition, cocaine can produce local anesthesia as well as vasoconstriction and cardiac stimulation. Among abusers, a form of cocaine known as crack is used widely. Crack is extremely addictive, and the risk for lethal overdose is high. According to the National Survey on Drug Use and Health, cocaine has declined. In 2014, 1.8 million Americans 12 years and older reported using cocaine in any form, compared to the 5.5 million in 2005. So, its forms. Cocaine is available in two forms: cocaine hydrochloride and cocaine base. Cocaine base is heat stable, whereas cocaine hydrochloride is not. Cocaine hydrochloride is available as a white powder that is frequently diluted before sale. Cocaine base is sold in the form of crystals that consist of nearly pure cocaine. Cocaine base is widely known by the street name of crack, a term inspired by the sound the crystals make when they are heated. So, the route of administration. Cocaine hydrochloride is usually administered intranasally. The drug is snorted and absorbed above the nasal mucosa into the bloodstream. A few users administer cocaine hydrochloride intravenously. Cocaine hydrochloride cannot be smoked because it is unstable at a high temperature. Cocaine base is administered via smoking, a process referred to as freebasing. Smoking delivers large amounts of cocaine into the lungs, where absorption is very rapid. Subjective and physiologic effects are equivalent to those elicited by IV injection. So, subjective effects and addiction. At usual doses, cocaine produces euphoria, similar to that produced by amphetamines. In a lab setting, individuals familiar with the effects of cocaine are unable to distinguish between cocaine and amphetamine. Cocaine causes euphoria through the inhibition of neuronal reuptake of dopamine, and therefore increases activation of dopamine receptors in the brain's reward circuit. As with many other psychoactive drugs, the intensity of subjective responses depends on the rate at which plasma drug levels rise. Because cocaine levels rise relatively slowly with intranasal administration and almost instantaneously with IV injection or smoking, responses produced by intranasal cocaine are much less intense than those produced by the other two routes. When crack cocaine is smoked, desirable subjective effects begin to fade within minutes and are often replaced by dysphoria. In an attempt to avoid the dysphoria and regain euphoria, the user may administer repeated doses at shorter intervals. This use pattern, termed binging, can rapidly lead to addiction. So, its acute toxicity. Overdose is frequent and deaths have occurred. Mild overdoses produce agitation, dizziness, tremors, and blurred vision. Severe overdose can produce hyperpyrexia, convulsions, ventricular dysrhythmias, and hemorrhagic strokes. Angina pectoris and myocardial infarctions may develop secondary to coronary artery spasms. Psychological manifestations of overdose include severe anxiety, paranoid ideations, and hallucinations. Because cocaine has a short half-life, symptoms subside in 1 to 2 hours. Although there is no specific antidote to cocaine toxicity, most symptoms can be controlled with drugs. IV diazepam or lorazepam can reduce anxiety and suppress seizures. Diazepam may also alleviate hypertension and dysrhythmias because they result from increased central sympathetic activity. If hypertension is severe, it can be corrected with IV nitroprusside. Dysrhythmias associated with the prolonging of the QT interval may respond to a hypertonic sodium bicarbonate. Although beta blockers may suppress dysrhythmias, they might further compromise coronary perfusion. Reduction of thrombus formation with aspirin can lower the risk for myocardial ischemia. Hyperthermia should be reduced with external cooling blankets. Chronic toxicity. When administered intranasally on a long-term basis, cocaine causes atrophy of the nasal mucosa and loss of sense of smell. In extreme cases, necrosis and perforation of the nasal septum has occurred. Nasal pathology results from local ischemia secondary to chronic vasoconstriction. Injury to the lungs can occur from smoking cocaine base. Its tolerance, dependence, and withdrawal, therefore. Strictly in animal models, regular administration of cocaine resulted in increased sensitivity to the drug and not a tolerance. Whether this holds true for humans is not 100% clear. The degree of physical dependence produced by cocaine is in dispute. Some observers report little or no evidence of withdrawal after cocaine discontinuation. In contrast, other reports symptoms similar to those associated with amphetamine withdrawal, dysphoria, craving, fatigue, depression, and prolonged sleep. So, our treatment of cocaine addiction, therefore. Although achieving complete abstinence from cocaine is extremely difficult, treatment can greatly reduce cocaine use. For those cocaine addict, psychological therapy is the cornerstone of treatment. This therapy is directed at motivating users to commit a drug-free life and then helping them work towards that goal. A combination of individual therapy and group drug counseling is most effective, producing a 70% reduction in cocaine use in 12 months follow-up. Can medication with cocaine addiction? To date, no drug has been proved broadly effective in treating cocaine abuse. However, ongoing work with 2 agents are encouraging. The anti-cocaine vaccine. Subjects receiving the vaccine develop antibodies that bind with cocaine and therefore render the cocaine inactive. The higher the antibody titer, the greater the reduction in cocaine use. The vaccine has been tested in mice, and human testing, started back in 2016. And then disulfiram, or antabuse. Subjects receiving a combination of disulfiram plus cognitive behavior therapy reduced their cocaine use from 2 or 3 times daily to half the times daily. Disulfiram is the same drug that was discussed already in Chapter 31 for treating alcohol abuse. Methamphetamine. The basic pharmacology of amphetamine family is discussed in Chapter 29. The discussion here is again limited to its abuse of methamphetamine. So, methamphetamine is a white crystalline powder that readily dissolves in water or alcohol. The drug may be swallowed, snorted, smoked, or injected intravenously. Owing to its potential for abuse, methamphetamine is classified as a Schedule II drug. Its patterns of abuse and use. Methamphetamine use is declining. According to the 2014 National Survey on Drug Use and Health, the use of methamphetamine by Americans 12 years and older continues to decline. As was discussed in Chapter 29, amphetamine acts primarily by increasing the release of norepinephrine and dopamine, and partly by reducing the reuptake of both transmitters. By doing so, methamphetamine produces arousal and an elevation of mood. Euphoria is likely, and talkativeness is prominent. A sense of increased physical strength and mental capacity has occurred. Self-confidence rises, and users feel little or no need for food or sleep. So its adverse psychological effects. All amphetamines can produce a psychotic state characterized by delusions, paranoia, and auditory and visual hallucinations, making patients look like they have schizophrenia. Although psychosis can be triggered by a single dose, it occurs more commonly with long-term abuse. Methamphetamine-induced psychosis usually resolves spontaneously after drug withdrawal. If needed, an antipsychotic agent can be given to suppress symptoms. Adverse cardiovascular effects. Because of its sympathomimetic actions, methamphetamine can cause vasoconstriction and excessive stimulation of the heart, leading to hypertension, angina pectoris, and dysrhythmias. Overdose may also cause cerebral and systemic vasculitis as well as renal failure. Changes in cerebral blood vessels can lead to strokes. Vasoconstriction can be relieved with an alpha-adrenergic blocker. Cardiac stimulation can be reduced with a mixed alpha and beta blocker. Bringing us to other adverse effects. By suppressing appetite, methamphetamine can cause significant weight loss. Use during pregnancy increases the risk for preterm birth, hypertension, placental abruption, intrauterine growth restrictions, and neonatal death. Heavy use can promote severe tooth decay, known informally as meth mouth. Causes include reduced salivation, grinding and clenching of the teeth, and increased consumption of sugary drinks, and neglect of oral hygiene. Finally, methamphetamine can cause direct injury to dopaminergic nerve terminals in the brain, leading to a prolonged deficit in cognitive and memory. Its tolerance, dependence, and withdrawal. Long-term use results in tolerance to mood elevation, appetite suppression, and cardiovascular effects. Although physical dependence is only moderate, psychological dependence can be intense. Methamphetamine withdrawal can produce dysphoria and a strong sense of craving. Other symptoms include fatigue, prolonged sleep, excessive eating, and depression. Depression can persist for months and is a common reason for resuming drug use. Its treatment, therefore. Methamphetamine addiction responds well to cognitive behavioral therapy. Only one such approach, known as the matrix model, combines group therapy, individual therapy, family education, drug testing, and the encouragement to participate in a non-drug related activity. At this time, no medications are approved for treatment. However, encouraging results have been achieved with two drugs, bupropion, or Wellbutrin, currently approved for major depression and smoking cessation, and modafinil, also known as Allergic, a non-amphetamine stimulant currently approved for the narcolepsy, shift work sleep disorder, and obstructive sleep apnea, hypopnea syndrome. In addition, drug ibudilast is currently in clinical trials. Preliminary results indicate that ibudilast may dampen cravings of methamphetamine and improve cognitive function. Which now brings us to marijuana and related preparations. Marijuana is the most commonly used illicit drug in the United States. More than 95 million Americans have tried it at least once, and in 2014, nearly 22 million Americans 12 years and older use marijuana. Among the youth, rates of daily marijuana use are the highest since the 1970s. Results from a 2012 Monitoring the Future survey shows that 10.4% of 8th graders and 25.5% of 10th graders reported using marijuana in the past year. Marijuana use among 12th graders has risen to 35.1%. Cannabis sativa, the source of marijuana. Marijuana is prepared from Cannabis sativa, the Indian hemp plant, an unusual plant that it has separate male and female forms. Psychoactive compounds are present in all parts of the male and female plants. However, the greatest concentration of psychoactive substance is found in the flowering tops of the female plant. The most common cannabis derivatives are marijuana and hashish. Marijuana's preparation consists of leaves and flowers of male and female plants. Alternatively, names for marijuana include grass, weed, pot, and dope. The term joint and reefer refers to marijuana cigarettes. Hashish is a dried preparation of the resinous exudate from female flowers. Hashish is considerably more potent than marijuana. Psychoactive components. The major psychoactive substance in cannabis sativa is the delta-9 tetrahydrocannabinoid, an oily chemical with high lipid solubility, also known as THC. The THC content of cannabis preparation is variable. The highest concentrations are found in the flowers of the female plant. The lowest concentrations are in the seeds. Depending on the growing conditions and the strain of the plant, THC in marijuana preparations may range from 1 to 11%. So how does it work? The psychological effects of THC result from activating specific cannabinoid receptors in the brain. The endogenous ligand for these receptors appear to anandamide, a derivative of arachidonic acid unique in the brain. The concentration of cannabinoid receptors is highest in brain regions associated with pleasure, memory, thinking, concentration, appetite, sensory perception, time perception, and the coordination of movement. There is evidence that marijuana may act in part through the same reward system as opioids and cocaine. Both heroin and cocaine produce pleasurable sensations by promoting the release of dopamine in the brain's reward circuit. In rats, IV THC also causes dopamine release. Interestingly, release of dopamine by THC is blocked by Narcan, a drug that blocks the effects of opioids. This suggests that THC causes the release of dopamine by first causing the release of the endogenous opioids. Which brings us to the pharmacokinetics. Administration via smoking. When marijuana or hashish is smoked, about 60% of the THC content is absorbed. Absorption from the lungs is rapid. Subjective effects begin in minutes and peak in 10 to 20 minutes later. Effects from a single marijuana cigarette may persist for 2 to 3 hours. Termination results from the metabolism of the THC to inactive products. Oral administration. When marijuana or hashish is ingested, practically all of the THC undergoes absorption. However, most is inactivated on the first pass through the liver. Therefore, only about 6 to 20% of the absorbed drug actually reaches the systemic circulation. Because of this extensive first-pass metabolism, oral doses must be 3 to 10 times greater than when smoked doses to produce equivalent effects. With oral dosing, effects are delayed and prolonged. Responses begin in 30 to 50 minutes and can last up to 12 hours. Behavioral and subjective effects. Marijuana produces 3 principal subjective effects: euphoria, sedation, and hallucination. This set of responses is unique to marijuana. No other psychoactive drug causes all 3. Because of this singular pattern of effects, marijuana is in a class by itself. So, effects of low to moderate doses. Response to low doses of THC are variable and depend on several factors, including the dosage size and route, setting of drug use, and expectations and previous experience of the user. The following effects, however, are common: euphoria and relaxation, gaiety, and a heightened sense of the humorous, increased sensitivity to visual and auditory stimuli, an enhanced sense of touch, taste, and smell, increased appetite and ability to appreciate the flavor of food, and distortion of time. Perceptions such as short spans seem much longer than they really are. In addition to these effects, which might be considered pleasurable, moderate doses can produce undesirable responses. Among these are impairments of short-term memory, decreased capacity to perform multi-step tasks, slowed reaction time and impairment of motor coordination, altered judgment and decision-making, temporal disintegration, decreased ability to perceive the emotions of others, depersonalization, and the reduced interpersonal interactions. During high-dose effects, in high doses, marijuana can have serious adverse psychological effects. The user may experience hallucinations, delusions, and paranoia. Euphoria may be displaced by intense anxiety, and the dissociative state may occur in which the user feels outside of him or herself. In extreme high doses, marijuana can produce a state resembling toxic psychosis, which can persist for several weeks. Because of the widespread use of marijuana, psychiatric emergencies caused by the drug are relatively common. Not all users are equally vulnerable to the adverse psychological effects of marijuana. Some individuals experience ill effects only at extreme high doses. In contrast, others routinely experience adverse effects at even a moderate dose. So, the effects of chronic use. Chronic excessive use of marijuana is associated with the behavioral phenomenon known as the amotivational syndrome, characterized by apathy, dullness, poor grooming, reduced interest in achievement, and disinterest in the pursuit of conventional goals. The precise relationship between marijuana and the development of syndrome is not known, nor is it certain that other factors may contribute. Available data do not suggest that the amotivational syndrome is due to organic brain damage. Its role in schizophrenia. Marijuana use is associated with an increased risk for schizophrenia. In young people with no history of psychotic symptoms, marijuana increases the risk for symptoms to occur. In people who already have symptoms, marijuana may prolong symptom persistence. In the stabilized schizophrenic person, marijuana may precipitate an acute psychotic episode. Its physiologic effects. So cardiovascularly, marijuana produces a dose-related increase in the heart rate. Increases of about 20 to 50 beats per minute are typical. However, rates to 140 beats per minute are not uncommon. Pretreatment with propranolol prevents marijuana-induced tachycardia. However, it does not block the drug's subjective effects. Marijuana causes orthostatic hypotension and a pronounced reddening of the conjunctiva. These responses apparently result from vasodilation. Its respiratory effects. When used acutely, marijuana produces bronchodilation. However, when smoked chronically, the drug causes airway constriction. In addition, chronic use is closely associated with the development of bronchitis, sinusitis, and asthma. Lung cancer is another possible outcome. Animal studies have shown that tar from marijuana smoke is a more potent carcinogen than the tar from cigarettes. Its effects on reproduction. Research in animals have shown multiple effects on reproduction. In males, marijuana decreases spermatogenesis and testosterone levels. In females, the drug reduces the levels of follicle-stimulating hormone, luteinizing hormone, and prolactin. Multiple effects may be seen in babies and children who were exposed to marijuana in utero. Some babies present with trembling, altered responses to visual stimuli, and a high-pitched cry. Preschoolers may have a decreased ability to perform tasks that involve memory and sustained attention. School children may exhibit deficits in memory, attentiveness, and problem solving. So, the altered brain structure. Long-term marijuana use is associated with structural changes in the brain. Specifically, the volumes of the hippocampus and the amygdala are reduced by an average of 12 to 7.1% respectively. We don't know if the volume reduction is due to the reduced cell size reduced synaptic density, or loss of glial cells, or neurons. Interestingly enough, hippocampal volume loss occurs primarily in the left hemisphere. Its tolerance and dependence, therefore. When taken in extreme high doses, marijuana can produce tolerance and physical dependence. Neither effect, however, is remarkable. Some tolerance develops to the cardiovascular, perceptual, and motor effects of marijuana. Little or no tolerance develops to subjective effects. To demonstrate physical dependence on marijuana, the drug must be given in a very high dose, and even then, the degree of dependence is only moderate. Symptoms brought on by the abrupt discontinuation of high-dose marijuana include irritability, restlessness, nervousness, insomnia, reduced appetite, and weight loss. Tremor, hyperthermia, and chills may occur too. Symptoms subside in 3 to 5 days. With moderate marijuana use, no withdrawal symptoms occur. So, its therapeutic use. In the US, there is technically no approved medical use for marijuana. However, the FDA has approved use for two purified cannabinoids, THC and dronabinol, an analog of the THC. A current third cannabinoid preparation, nabiximols, is approved in Canada. So, approved uses for cannabinoids. The suppression of emesis. Intense nausea and vomiting are common side effects of cancer chemotherapy. In certain patients, the response can be suppressed more effectively with cannabinoids than with traditional antiemetics. At this time, again, the two preforementioned cannabinoids are available for antiemetic use. Dronabinol, a synthetic form of THC, is a Schedule III drug. Nabilone, a THC derivative, is a Schedule II drug. Dosage forms and dosages will be presented in further detail in Chapter 64. Appetite stimulation. Dronabinol is FDA approved for stimulating appetite in patients who have AIDS. By relieving anorexia, treatment may prevent or reverse loss of weight. The relief of neuropathic pain. In 2005, Canadian regulators approved nabiximols, or Sativex, administered by oral spray, for treating neuropathic pain caused by multiple sclerosis. Nabiximols is a mixture of two cannabinoids, THC and cannabidiol. Because the cannabinoids in Sativex are absorbed through the oral mucosa, the product has a rapid onset, while being devoid of the dangerous tars in marijuana smoke. In the US, nabiximols is under study for treating intractable cancer pain. However, the drug is not yet approved in the US and cannot be legally imported, owing to its current classification as a Schedule I substance. So, the unapproved use of cannabinoids in glaucoma. Patients who have glaucoma, smoking marijuana may reduce intraocular pressure. Unfortunately, marijuana may also reduce blood flow to the optic nerve, so we don't know if the drug improves the vision or not. Multiple sclerosis. Whether smoked or ingested, marijuana appears to reduce spasticity and tremor in MS. Oral cannabinoids may also reduce the urge incontinence. As discussed earlier, cannabinoids can reduce neuropathic pain of MS. Leading us to the medical research on marijuana. Proponents of making marijuana available by prescription argue that smoked marijuana can reduce chronic pain, suppress nausea caused by chemotherapy, improve appetite in patients with AIDS, and lower intraocular pressure in patients with glaucoma, as well as suppress spasticity associated with MS and spinal cord injuries. However, the evidence supporting most of these claims are considered weak, largely because of federal regulations had effectively barred marijuana research. Keep in mind, this research is from 1999. Two developments opened the doors to marijuana research. First, an expert panel convened by the National Academy of Sciences Institute of Medicine recommended that clinical trials on marijuana proceed because smoking marijuana poses a risk for lung cancer and other respiratory disorders. The panel also recommended development of rapid onset non-smoke delivery systems. In response to this report and to pressure from scientists and voters, the government created new guidelines that loosened restraints on marijuana research. Under those guidelines, researchers will be allowed to purchase marijuana directly from the federal government. The only catch is that all proposed research must be approved by the FDA, the National Institute on Drug Abuse, and the Drug Enforcement Agency. Despite these formidable obstacles, at least one institute, the Center of Medicinal Cannabis Research at the University of California, has begun coordinating and supporting research on medical marijuana. Trials focused on HIV-related cachexia, neuropathic pain, nausea and vomiting, associated with cancer chemotherapy, and muscle spasticity associated with MS and other diseases. The legal status of medical marijuana. We're skipping over these sections mostly because regulation has changed tremendously in 2025 compared to the 2012 when this book was written, so we're going to jump over these sections here. In comparison of marijuana with alcohol. In several important ways, responses to marijuana and alcohol are quite different. Whereas increased hostility and aggression are common sequelae of alcohol consumption, aggressive behavior is rare among marijuana users. Although loss of judgment and control can occur with either drug, these losses are greater with alcohol. For the marijuana user, increased appetite and food intake are typical. In contrast, heavy drinkers are often nutritionally deficient. Lastly, whereas marijuana can cause toxic psychosis, dissociative phenomena, and paranoia, these severe acute psychological reactions rarely occur with alcohol. The synthetic marijuana. Synthetic cannabis blends showed up on the market in the early 2000s. They became popular because of their availability and their lack of traces in drug tests. They are initially legal because they are thought to contain blends of natural herbs sprayed with chemicals that mimic the effects of THC. These chemicals come in two classes, the THC analogs and other compounds. Although synthetic marijuana was once thought harmless, an American Association of Poison Control Center reported more than 7,000 calls regarding the synthetic marijuana in 2015 alone. In addition, civil deaths and many episodes of florid psychosis and toxicity are possibly related to synthetic marijuana use. Side effects included hypertension, nausea, vomiting, anxiety, agitation, paranoid behavior, hallucinations, and catatonic states. By 2011, the FDA had placed many of these chemicals on the controlled substance list as Schedule I drugs, making them illegal to possess. Moreover, more than 500 compounds exist, therefore synthetic marijuana is still technically available. Many organizations, including the US military, have banned all similar compounds. Which brings us to our psychedelics. The psychedelics are a fascinating drug family for which LSD can be considered the prototype. Other family members include mescaline, the dimethyltryptamine, psilocin, and salvia. The psychedelics are so named because of their ability to produce what has been termed a psychedelic state. Individuals in this state show an increased awareness of sensory stimuli and are likely to perceive the world around them as beautiful and harmonious. The normally insignificant may assume exceptional meaning. The self may seem split into the observer and the doer, and the boundaries between self and non-self may fade, producing a sense of unity with the cosmos. Psychedelic drugs are often referred to as hallucinogens and psychotomimetics. These names reflect their ability to produce hallucinations as well as mental states that resemble psychosis. Although psychedelics can cause hallucinations and psychotic-like states, they are not the most characteristic effects. The characteristics that truly distinguish the psychedelics from other agents is their ability to bring on the same type of alteration in the thought, perception, and feeling that otherwise would occur only in dreams. In essence, the psychedelics seem able to activate mechanisms for dreaming without causing unconsciousness. So, let's talk about LSD, its history. The first person to experience LSD was a Swiss chemist by the name of Albert Hofmann. In 1943, 5 years after LSD was first synthesized, Hofmann accidentally ingested a minute amount of the drug. The result was a dreamlike state accompanied by perceptual distortions and vivid hallucinations. The high potency and unusual actions of LSD led to the speculation that it might provide a model for studying psychosis. Unfortunately, that speculation did not prove correct. More extensive research had shown that the effects of LSD cannot equate with idiopathic psychosis. With the realization that LSD did not produce model psychosis, medical interest in the drug declined. Not everyone, however, lost this interest. In the 1960s, non-medical experimentation flourished. This widespread use caused substantial concern in the social circles, and by the 1970s, LSD was classified as a Schedule I substance. Nonetheless, street use of LSD continues to happen. So, its mechanism of action. LSD acts at multiple sites in the brain and spinal cord. However, effects are most prominent in the cerebral cortex and the locus coeruleus. Effects are thought to result from the activation of serotonin 2 receptors. This concept has been reinforced by the observation that ritonserin, a selective blocker of serotonin 2 receptors, may prevent the effects of LSD in animals. Time course. LSD is usually administered orally, but can also be injected or smoked. With oral dosing, initial effects can be felt in a few minutes. Over the next few hours, responses become progressively more intense and then finally subside 8 to 12 hours later. Subjective and behavioral effects. Responses to LSD can be diverse, complex, and changeable. The drug can alter thinking, feeling, perception, sense of self, and the sense of relationship with the environment and other people. LSD-induced experiences may be sublime or terrifying. Just what will be experienced during any particular trip cannot be predicted. Perceptual alterations can be dramatic. Colors may appear iridescent or glowing. Kaleidoscopic images may appear, and vivid hallucinations may occur. Sensory experiences may emerge so that colors seem to be heard and sounds seem to be visible. After images may occur, causing current perceptions to overlap with preceding perceptions. The LSD user may feel a sense of wonderment and awe at the beauty of commonplace items. LSD can have a profound influence on affect. Emotions may range from elation, good humor, and euphoria to sadness, dysphoria, and fear. The intensity of emotion may be overwhelming. Thoughts may turn inward, attitudes may be re-evaluated, and old values assigned new priorities. A sense of new and important insight may be felt. However, despite these intensities of these experiences, enduring changes in beliefs, behavior, and personality are considered rare. The psychologic effect. LSD has few psychological effects. Activation of the sympathetic nervous system can produce tachycardia, elevation of blood pressure, mydriasis, piloerection, and hyperthermia. Neuromuscular effects include tremor, incoordination, hyperreflexia, and muscular weakness, which also may occur. Its tolerance and dependence, as well as toxicity. Tolerance to LSD develops rapidly. Substantial tolerance can be seen after just 3 or 4 daily doses. Tolerance to subjective and behavioral effects develop to a greater extent than to the cardiovascular effect. Cross-tolerance exists between mescaline and psilocybin, but not with DMT, because DMT is similar to LSD. The absence of cross-tolerance is surprising. There is no cross-tolerance with amphetamines or THC. Upon cessation, LSD use tolerance rapidly fades. Abrupt withdrawal of LSD is not associated with abstinence syndrome. Therefore, there is no evidence of physical dependence. Toxic reactions are primarily psychological. LSD has never been a direct cause of death, although fatalities have occurred due to accidents and suicides. Acute panic reactions are relatively common and may be associated with a fear of disintegration of self, such as bad trips can usually be managed by a process of talking down. Panic episodes can also be managed with an anti-anxiety agent, which would include diazepam. Neuroleptics may actually intensify the experience and therefore their use is questionable. A small percentage a small percentage of former LSD users also experience episodic visual disturbances, referred to as flashbacks by users, and hallucinogens persisting perception disorder by their clinicians. These disturbances may manifest as geometric pseudo-hallucinations, flashes of color, or positive after images. Visual disturbances may be precipitated by several factors, which include marijuana use, fatigue, stress, and anxiety. Phenothiazines exacerbate these experiences rather than provide relief. HPPD appears to be the cause by permanent changes in the visual system. In addition to panic reactions and visual disturbances, LSD can cause other adverse psychological effects. Depressive episodes, dissociative reactions, and the distortion of body image may also occur. When an LSD experiment has been intensely terrifying, the user may be left with a persistent residual fear. The drug may also prolong psychotic reactions. In contrast to acute effects, which differ substantially from symptoms of schizophrenia, prolonged psychoactive reactions mimic schizophrenia faithfully. So, potential therapeutic uses. LSD has no recognized therapeutic application. The drug has been evaluated in subjects with alcoholism, opioid addiction, and psychiatric disorders, including depression, anxiety, and OCD. In addition, LSD has been studied as a possible means of promoting psychological well-being in a patient with terminal cancer, with the possible exception of some psychiatric disorders. LSD has proved either ineffective or impractical. Salvia. Salvia divinorum is a hallucinogenic herb native to southern Mexico and to Central and South America. Its primary psychoactive component is salvinorin A potent activator of the kappa opioid receptors. The genus Salvia, a part of the mint family, is commonly known as sage. Therefore, the colorful street names for S. divinorum is magic mint, diviner sage, and sage of the seers. Salvia is legal in some states, illegal in others, and not yet regulated under the Controlled Substance Act. Salvia is used extensively in the US, primarily by the teens and young adults. In 2011, 5.9% of high school seniors reported using the drug in the past year. About 1.8 million Americans older than 12 years report having used salvia at least once in their lives. So, how is salvia administered? Among Mexican Indians, the traditional method is to chew the leaves or to drink a liquid extract. In contrast, recreational users usually smoke the dried leaves, either in a pipe or rolled in a joint. When smoked or when smoke is inhaled, salvinorin A undergoes rapid absorption in the lungs. As a result, the psychological effects begin quickly and then quickly fade. Like other psychedelic drugs, salvia induces a dreamlike state of unreality. Users may lose awareness of their own body and of the room they are in. They may feel they are floating, traveling through time and space, or merging rather transforming into objects. Some feel that they are being twisted or pulled. There may be a sense of overlapping realities and of being in several places at once. Speech may become slurred and sentences may lack fluent structure. Uncontrollable laughter may break out. Possible physical effects include chills, dizziness, nausea, incoordination, and bradycardia. Whether salvia poses long-term health risks have not yet been studied. However, we do know that Mexican Indians have used the drug for generations with no apparent ill effects. Leading us to mescaline, psilocin, psilocybin, and the dimethyltryptamine. In addition to the LSD and salvia, the family of psychedelic drugs include the above stated and several related compounds. Some psychedelics are synthetic and some occur naturally. DMT and LSD represent a synthetic compounds. Mescaline, a constituent of the peyote cactus, and psilocin and psilocybin, constituents of the magic mushrooms, represent compounds found in nature. The subjective and behavioral effects of the miscellaneous psychedelic drugs are similar to those of LSD. So, like LSD, these drugs can elicit modes of thought, perception, and feeling that are normally restricted to dreams. In addition, they can cause hallucinations and induce mental states that resemble psychosis. The miscellaneous psychedelics differ from LSD with respect to potency and time course. LSD is the most potent of the psychedelics, producing its full spectrum of effects at doses as low as 0.5 micrograms per kilogram. Psilocin and psilocybin are 100 times less potent than LSD, and mescaline is 4,000 times less potent than LSD. Whereas the effects of LSD are prolonged, the effects of mescaline and DMT are shorter. Responses usually favor than 8 to 12 hours for mescaline, and for DMT they fade within 1 to 2 hours. None of these psychedelics are approved for medical use, however, and the use of psilocybin in patients with terminal cancer and OCD is still under investigation. Dextromethorphan, or DXM, is a cough suppressant widely available in over-the-counter cough and cold remedies, which was discussed in Chapter 61. At the low doses needed for cough suppression, DXM is devoid of psychological effects. However, at doses 5 to 10 times higher, DXM can cause euphoria, disorientation, paranoia, and an altered sense of time, as well as visual, auditory, and tactile hallucinations. These effects are produced by dextromethorphan, a metabolite of DXM that blocks the receptors of the N-methyl D-aspartate. Note that this is the same mechanism used by phencyclidine and ketamine. Many of the products that contain DXM also contain other drugs, including Tylenol, antihistamines, phenylephrine, and pseudoephedrine. Therefore, when excessive doses are taken, users are subjective to toxicity from these compounds as well as DXM itself. The principal users of DXM are adolescents and teenagers. Between 1999 and 2004, reports of DXM abuse in these groups rose tenfold. Many products containing DXM, including the Coricidin HPB cough and cold, Robitussin DM, and Vicks NyQuil cough syrup. Somewhat outdated. So that brings us to MDMA, also known as methylene dioxymethamphetamines. The common word ecstasy is a complex drug with stimulant and psychedelic properties. The drug is structurally related to methamphetamines and mescaline. Low doses produce a mild LSD-like psychedelic effect. Higher doses produce amphetamine-like stimulant effects. These effects result from blocking reuptake of serotonin and promoting the release of serotonin, dopamine, and norepinephrine. Although MDMA can produce effects that are clearly pleasurable, it can also be dangerous. The biggest concern is neurotoxicity, seizures, excessive cardiovascular stimulation, and hyperthermia, and its sequelae. Ecstasy is classified as a Schedule I drug. So, its time course and dosage. Ecstasy is usually dosed orally, but also can be snorted, injected, or inserted as a rectal suppository. With oral administration, effects begin in 20 minutes, peak in 2 to 3 hours, and persist for 4 to 5. The usual dose is about 100 milligrams or less. So, who uses ecstasy and why? Well, it's used primarily by the adolescent and young adults in cities, in suburbs, and rural areas. According to a survey conducted in 2014, about just shy of 1% of 8th graders, 2.3% of 10th graders, and 3.6% of 12th graders had used ecstasy in the past year. So why take it? Because it makes them feel very good. The drug can elevate mood, increase sensory awareness, and heighten sensitivity to music. It can also facilitate interpersonal relationships. Users report a sense of closeness with others, lowering of defenses, reducing anxiety, enhancing communication, and increased sociability. So, what are its adverse effects then? Well, ecstasy is not free of risk. The drug can injure serotonergic neurons, stimulate the heart, and raise body temperature to a dangerous level. In addition, it can cause neurologic effects, such as seizures, spasmodic jerking, jaw clenching, and teeth grinding, and a host of adverse psychological effects, including confusion, anxiety, paranoia, panic attacks, visual hallucinations, and suicidal thoughts and behavior. Every year, ecstasy is associated with several thousand admissions to the emergency department, mainly because of a seizure. Ecstasy can damage serotonergic neurons, perhaps irreversibly. When administered to rats and primates in doses only 2 to 4 times greater than those that are produced hallucinations in humans, ecstasy causes irreversible destruction of serotonergic neurons, resulting in passivity and insomnia. At least 3 lines of evidence suggest that ecstasy is also neurotoxic in humans. First, ecstasy causes dose-related impairment of memory, a brain function mediated in part by serotonin. Memory impairment persists long after ecstasy was last taken. Second, the cerebrospinal fluid of long-term ecstasy users contains abnormally low concentrations of serotonin metabolites, suggesting a loss of serotonergic neurons. Third, using positron emission tomography to study former ecstasy users, researchers demonstrated decreased binding of ligand selective for the serotonin transport, indicating damage to the serotonergic neurons. In the study, reduction in ligand binding correlated with the extent of ecstasy use and not with the duration of abstinence. Ecstasy can cause hyperthermia in association with dehydration, hyponatremia, and rhabdomyolysis. Treatment consisted of rapid cooling, rehydration, and administering dantrolene, a drug that relaxes skeletal muscle, thereby reducing heat generation and the risk for rhabdomyolysis. The risk for hyperthermia and dehydration could be greatly reduced by providing ample fluids at dance parties, known as raves, and other events where ecstasy is likely to be used. Because of its amphetamine-like actions, ecstasy can increase the heart rate, blood pressure, and myocardial oxygen consumption. Remarkably, the increase in heart rate and blood pressure equal those produced by maximal doses of dobutamine, a powerful adrenergic agonist, which is discussed in Chapter 13. Cardiovascular stimulation poses a special risk to users with heart disease. So, potential medical use. Despite its potential for adverse effects, ecstasy also has the potential for therapeutic good, owing largely to its ability to decrease feelings of fear and defensiveness, as well as promote feelings of love, trust, and compassion. In small clinical trials, ecstasy for treatment of post-traumatic stress disorder and in patients with severe anxiety related to terminal cancer was considered promising, revealing reduced fear of death and a decreased anxiety in patients who took ecstasy. Inhalants. The inhalants are a diverse group of drugs that have one characteristic in common: administration via inhalation. These drugs can be divided into anesthetics and organic solvents. So, anesthetics. Providing that dosage is modest, anesthetics produce subjective effects similar to those of alcohol. The anesthetics can be abused most, or the anesthetic that is most commonly been abused is nitrous oxide, or laughing gas, and ether. One reason for the popularity of these drugs is ease of administration. Both agents can be used without exotic equipment. For nitrous oxides, ready availability also promotes use. Small cylinders of the drug marketed for aerating whipping cream can be purchased without any kind of restriction. Organic solvents. A wide assortment of solvents have been inhaled to induce intoxication. These compounds include toluene, gasoline, lighter fluid, paint thinner, nail polish remover, benzene, acetone, chloroform, and model airplane glue. These agents all are used primarily by children and very poor people who, because of age or insufficient funds, lack access to more conventional drugs of abuse. In recent years, the use of inhalants by young children and teens has been rising. So, administration. Solvents are administered by three processes, referred to as bagging, huffing, or snuffing. Bagging is performed by pouring a solvent in a bag and inhaling the vapor. Huffing is performed by pouring the solvent on a rag and inhaling the vapor. And sniffing is performed by inhaling the solvent directly from its container. So, the acute effects of organic solvents are somewhat like those of alcohol, which include euphoria, impaired judgment, slurred speech, flushing, and CNS depression. In addition, these compounds can cause visual hallucinations and disorientation with respect to time and place. A high dose can result in sudden death. Possible causes include anoxia, respiratory depression, and vagal stimulation, as well as dysrhythmias. Chronic toxicity. Prolonged use is associated with multiple toxicities, such as an example for chloroform, which is toxic to the heart, liver, and kidneys, and toluene, which can cause severe brain damage and bone marrow depression. Many solvents can damage the heart, which would cause, for instance, fatal dysrhythmias. The management of an acute toxicity is strictly supportive. The objective is to stabilize vital signs, as we have no antidotes for volatile solvents. Which leads us to our last section, anabolic steroids. Many athletes take anabolic steroids, or androgens, to enhance athletic performance. The principal benefit is increased muscle mass as well as strength. Because of the massive doses that are employed, the risk for adverse effects is substantial. With long-term steroid use, an addiction syndrome develops. Because of their abuse potential, most androgens are now classified as Schedule III drugs. The basic pharmacology of androgens and their abuse by athletes will be discussed in further detail in Chapter 50. And that concludes our chapter here for today. I thank you all for listening as always, and you have a wonderful rest of your day.